Good evening, everybody, and welcome to the Western New South Wales COVID-19 response, the update for general practices. My name's Anthony. I'm the Media and Communications Coordinator with Western New South Wales PHN. I'll be your mediator for this evening. It's great to have so many people joining us for this evening's webinar, which is going to have plenty of very important and vital information for you this evening as well. First up, though, I'd like to pass to our CEO, Andrew Harvey, for the acknowledgement of country.
Thanks, Anthony, and welcome everybody to this important webinar. Can I acknowledge the traditional custodians of the land in which we're meeting? Regardless of where we meet in Western New South Wales, we're meeting on Aboriginal country, or for that matter across Australia. And across our Western New South Wales PHN footprint, there are 16 Aboriginal nations. Can I also pay respects to elders past, present and emerging, and also acknowledge if there are Aboriginal people on the call tonight, acknowledge them and also acknowledge the work that Aboriginal people do in our organisations and across our region. So yeah, welcome. I'm not going to say much more. We've all been very busy on the COVID response, and tonight is really giving you an update of where things are at, and from a PHN perspective. Thank you for your interest, and I'm going to hand back to Anthony.
Tonight's program will be covering off with Western New South Wales PHN's COVID-19 response with Tab Jones. Dr. Alex Gannam, a GP from South Mudgee Surgery, has been kind enough to join us. He'll talk about primary care respiratory clinics in our communities. And from a Western New South Wales Local Health District perspective, we'll talk about COVID-19 management, response, fever clinics and testing with Dr. Dan Stewart, the Director of Emergency Medicine at the Dubbo Health Service. But to start us off this evening, Tabitha Jones on the COVID-19 project response, or she is the COVID-19 project response coordinator with the PHN. Tab.
Thank you very much, Anthony, for that. I would just like to start by welcoming everybody along tonight, and thank you for taking time out of all your busy schedules, because I know that everyone is really busy right now, working in their own day jobs and trying to keep on top of COVID-19. So thank you for taking the time. So for those of you who don't know me, my name is Tabitha Jones. I'm working as the response officer for this project. I'm a pharmacist, that's my background, and I manage projects and have done a lot of work in integration and innovation. So this is a job that has been quite an interesting role for me, but I've actually really been enjoying working with the practices who've taken up the challenge, I guess, to set up respiratory clinics. So I'm going to give you a bit of an overview of how the Primary Health Network has been working towards responding to COVID-19, and I will touch on some information about the respiratory clinics. And I'm happy to talk to people after this, or throughout the week, and give them an update or some information as well. But please watch our website and our communications, because we are producing a twice weekly communication and trying to keep everybody updated as things progress. Just a little quick update from today, a snapshot. At the moment, there are 3 active cases in Western LHD, keeping in mind that we also cover Far West when we talk about our PHN area as well. So people may or may not be familiar with the concept of the primary care respiratory clinics, which is an initiative that the federal government rolled out, or has been rolling out, in response to the threat of COVID-19. And the government's aim was to establish 100 private practice respiratory clinics nationally. So EOIs were invited, and the Department of Health oversaw this process. And we've been submitting EOIs basically guided by where the Department of Health has asked us to look to establish clinics as part of this solution. There'll be dedicated services, and the idea is that people with mild to moderate symptoms can present to the clinics, and they can be available to really enable the swabbing of these patients where that's relevant, and to care for these patients in the primary care setting. The real concept behind this is to keep people out of the hospital, to keep people out of general practice waiting rooms that potentially may have COVID-19. And the goal of this is really to reduce the transmission. And this is twofold. It's to reduce transmission to the workforce, so keeping our health professionals safe and able to continue to do the work that they need to do right now, and also to keep vulnerable patients safe. So the people that do frequent the hospital or do frequent general practice often have chronic diseases and complications, where right now we need to be protecting these people, but we also need them to be able to still access services. So part of this strategy was to optimise the use of PPE, which we know has been an issue for us in Australia. And again, we don't have all the solutions to this right now, but we need to be able to utilise the guidelines and the PPE that we have judiciously within our clinics to be able to make sure that we keep people safe and continue to treat patients. It's complementary to the current primary health system and the work that New South Wales Health has been doing in this space. And these practices are independently run by a lead practice. So that was put forward by general practices with accreditation. And essentially our clinics will be led by a lead organisation, but in partnership with other practices, other practitioners who would like to support them, maybe through workforce, and really to provide these services to our communities to try and support the work that's already being done. So just to give you an update of where we're at with our primary care respiratory clinics. So we started with consultation, and I think lots of you probably came along to our consultation meetings in April. So we consulted with Orange, Bathurst, Dubbo and Broken Hill because this was how we were instructed to begin from the government. So from those meetings, we accepted expressions of interest. And I can tell you that Bathurst commenced today. So we've actually had one respiratory clinic begin operation in Bathurst. Dubbo has proposed that they will begin operations next Monday, the 4th of May, and Orange has proposed that they will open on the 18th of May. So keeping in mind that these dates are not set in stone, but at the moment this is what we're working towards, to be able to have these clinics open and operational and able to provide services to the communities. We also have Cobar, Mudgee and Cowra who have proceeded to the contract phase with the Department of Health, and we have Broken Hill and Coonamble just with EOIs that have been submitted to the government. So this is just, I guess, a summary of where we're at right now. So to give you an update on the model, I suppose that the respiratory clinics will operate under, they're in dedicated premises and they had to meet criteria as identified by the government. We're providing, and Aspen Medical has also been providing training and support so that there's good management of infection control, and they're operating in line with New South Wales Health guidelines in terms of testing and swabbing patients, which Dan Stewart will give us some more insight into. They'll be staffed by existing practitioners in our region to assess respiratory cases, and these may be COVID-19 and they may be influenza and other respiratory conditions. So really to look after the people who are presenting with respiratory symptoms and be able to manage these patients and then get them back into primary care when they're not going to be contagious or where we minimise the risk of spreading infection. There's different types of respiratory clinics that are emerging, and really these have been based on local resources. So we have to imagine that we're setting up these clinics in towns and with practices who already run existing services. So we need to work with the resources that we have. And what has eventuated from that is respiratory clinics that are being set up in a new location. So Dubbo, for example, is being set up in an existing building as a new respiratory clinic under the guidance of DMAG, of Dubbo Medical and Allied Health Group. Some of them have been established in existing practices where practices have seen the ability to perhaps turn part of their existing practice or their facility into another facility so that they can adequately control infection, have dedicated entrances and exits, and be able to take care of patients in an existing part of their practice. And we're also working with the government and talking about possible mobile models. So it's really not a one-size-fits-all, it's about solutions that will work for the region. Just to give you a bit of an overview, so I've already mentioned they'll be led by a general practice or an AMS or ARCHO. Independently run, so the clinics will run these clinics the way that they see best, and we've got some amazing clinicians working in these clinics and getting the staff skilled up and working with some clinical leads to really provide good care. They're designed to be flexible to the needs of the community, so this refers to things like operating hours, and the clinics are opening with a set number of hours because they're via booked appointments. However, we have a lot of willingness for these to flex depending on what the demand looks like within our communities over the coming weeks and months. Again, I'll just mention to reduce presentations to hospital where patients are mild to moderate, presentations to primary care where there's a risk of transmission of infection, and to help create safe spaces for patients again, because something that we have noticed is a downturn in patients presenting to hospital and to general practice and primary care for their regular chronic disease management. And telehealth has formed part of the solution of reaching out and providing services to these patients. But we do also want to help try and create safe spaces where patients do need to be seeking and seeing clinicians. So, in terms of referring patients to the clinic, and we get more detail about this, I'm just giving you a quick overview. Basically, these are designed to be short-term clinics for a patient to attend, to be assessed by a doctor or a nurse and supported by the New South Wales guidelines. Patients to be encouraged, we're encouraging them to contact a regular GP, make an appointment, either face-to-face or most likely through, and where there's a need for this, and then refer to the clinic. Respiratory clinics will be done through the hot doc system, and that's what the government has required for these clinics. The clinics will also have designated phone and fax services, so you'll be able to refer a patient and send information on to follow your patient. That's an important part of the care as well. And all those details will be made available to practices in our region, and they'll be available on the website. Just to give you a bit of information about results and GP follow-up, because we have been getting a lot of questions around this. So the pathology results provided by the clinic will be given to the regular GP and a shared a summary in the My Health record, so that this is another way that we can have a record of that contact made for future reference. Can you change the slide? So that's, I guess, a bit of a nutshell about respiratory clinics, and Alex will expand on that from a GP perspective. I just need to probably thank and I guess give you an idea of what else our primary care response has entailed. So our response to the COVID-19 situation, it hasn't just been solely focused around the establishment of respiratory clinics. So the PHN internally has been doing an amazing amount of work to be able to support all primary care clinicians in this time, and it has been a time of increased stress, I think increased demand and increased need for support and information. So from our PHN perspective, we've really reallocated roles, I guess, or enhanced roles within our own team to try and be able to support the vast array of clinicians that work in our region and are responding to COVID-19. So we've reoriented some of our team to be liaising and supporting the aged care services. We've always had immunisation support, but this has been a really important role right now to be able to support the providers who are giving flu vaccinations and running flu clinics, and making sure that we take care of the other needs in terms of immunisation and keeping clinicians safe who are immunising. The practice support team has been on the ground delivering huge amounts of masks and basically responding to all the day-to-day requests and needs of our practices. We're working around supporting our AMSs, and we're also working to support our clinics with access to cultural safety training, as we realise that in our communities we're setting up new facilities that need to be for everyone in our communities. So we're really trying to work on how we work with our AMSs and make the facilities culturally safe and supportive of all members of the community. We're also doing some work around telehealth, and I'll touch on IRAD, our support and our pilot of IRAD in Dubbo in a moment. We're also been establishing or implementing health pathways. So you may be familiar with health pathways. A lot of PHNs use health pathways as a way to inform best practice and pathways to care. So we are doing this essentially around the COVID-19 work that we're doing, and this will be made available and live next week. So clinicians will have access to health pathways for COVID-19 to be able to access the pathway, the local pathway, the regional pathway, and data to support this care. We've also implemented some pharmacy support. So what we realised is our pharmacists have been on the front line in this time, and they've been quite challenged. Pharmacists have been, needing to work out new ways to operate, to triage patients and to stay safe as they continue to run their businesses. So we've implemented some triage guidelines and some education for our pharmacists, and we have been ramping up our education around COVID-19 and trying to be responsive to the needs of healthcare professionals and the respiratory clinics and, all of our providers as we've been through this, I guess, uncharted times. As well as the PHN support, I need to actually extend a really big thank you to New South Wales Health. So when we had our meetings, we realised pretty quickly that we needed some clinical leadership around this work. And so we have had the amazing support of Dr. Ivy Chua of Dubbo Family Medical. And she has really taken a strong lead on helping us with our protocols, helping us with our clinical information. And we've also been supported by Dr. Daniel Stewart, who you'll hear from, and Dr. Jacob Williams in terms of delivering information sessions to general practice and supporting us as we develop protocols for our clinics and also work with our practices. And in terms of communications, I did mention that we've had our twice weekly updates going out, and I would urge you to sign up to these if you haven't done that already, because that's where a lot of this information will be distributed through. But we've also implemented a WhatsApp update. So for anyone who is a bit tech savvy and would like an update via WhatsApp, that's another avenue. And we have clinical leadership meetings that have started up to support our clinics as well. So these clinicians have the opportunity to have input and, with one another as doctors and nurses working in the clinics, and also with some of the clinical leaders as well. So I did touch on education support, and we have had significant input from our clinical leaders around this, and I thank them for the sessions that they've been helping us to provide for our GPs, for our pharmacists, and there's more in the pipeline. So we're working with the public health unit on some work around infection control, and we're trying to make that available to general practice, Aboriginal medical services, pharmacies and aged care. So all the different groups that we've identified that are really needing support and some training right now. So I just wanted to touch on IRAD because this might be something that you haven't heard about. So IRAD is a program that was developed by Southwestern Sydney PHN, and it's a program that we're going to pilot on Broken Hill as trial sites to see if this is a good way to work when we're looking across services. So IRAD stands for Integrated Real-Time Active Data. So basically it's a software that allows us to share information between hospitals, between general practice and other health professionals. So we'll give you more information as this rolls out, but at the moment an expression of interest is open to practices in Dubbo and Broken Hill as part of this pilot. And I just have to give a little plug, I guess. We have a lot of community support as well for our respiratory clinics. There's been a lot of interest in the work that we've been doing. And there's a group called the Scrub Cap Angels who make scrub caps, of course, in our region for people who are working in health. And they have made a beautiful donation of over 100 scrub caps to our clinics to support and say thank you to the clinicians that have put their hand up to come on board. So I guess for me, I would really just like to say thank you. And I guess, the purpose of a lot of this is to say there's a lot of people who've been supporting the work that we've been doing and the work in our region to minimise the impact of coronavirus. And I think that tonight is an opportunity to say thank you and recognise the amount of help and input that we've had in our response to them. And just in terms of questions, if you send any questions to the chat box, we will address any questions that you have at the end of the evening. I'm happy to be contacted for further inquiries regarding this, and my details are available on the PHN website and have them made available to you after.
Thanks for that, Tab. Time to welcome to the microphone GP from South Mudgee Surgery, Dr. Alex Gannam. Alex.
Look, thanks very much, Tony. I hope everyone can hear me very clearly. I'm a GP in Mudgee. I've been working in Western New South Wales since 1995. I've worked in a few towns, Narromine, Wellington. I've worked in Dubbo and ONG, and I've also worked in the ED in Dubbo. We've resided in Mudgee for the last, since 1996. And I'm here as a GP, work at the hospital on the ED roster and as a VMO. I did obstetrics here for 17 years. At the moment, we've got 2 registrars and a full-time medical student from URW. Look, next slide, please. Look, just a little bit about Mudgee, because this is very much it's very much an area approach and how we interpret it for our communities. According to the Australian Bureau of Statistics, we've allegedly got a population of 10,923 as of 216. I'm sure that's a little bigger than what it was. At the time, 10.7% of our population was over the age of 70. According to council website, the district itself, which includes Mudgee, Golgong, Ralston and Kandos, is 24,826 people. But quite a few people. We've got 2 practices in Mudgee, 2 large practices. We've got a practice in Golgong and practice in Ralston, Kandos, servicing the region. Mudgee itself has got a hospital that provides not only medical cover but also ONG, and we've got approximately 31 beds. That includes 8 maternity beds, 4 dialysis beds and a couple of day stay beds. And importantly, we've got 3 aged care facilities in town. Next slide, please. I've been asked to cover a few things and I'll whiz through these. So firstly, what's Mudgee's vision, or should I say the vision that Gary Moore and I have had for this clinic, because Gary has been driving this, my colleague, quite hard since the inception. The importance of keeping unwell people out of hospital and primary care. Thirdly, how your clinic team, or how our clinic team has been developed, and partnership with council and other practice. I must say a big welcome to Brad Cam, our local General Manager for Mid-Western Regional Council. He's joining us this evening. I'm glad that Brad's come along to get a bit of an insight into what's happening on a regional basis. 4, working with New South Wales Health Guidelines and 5, pathology, and I've thrown in a few things, notes, continuity of care. Next slide. So look, we became aware of the need for a fever respiratory clinic really about 4 or 5 weeks ago, when I attended the first teleconference with Western New South Wales PHN, and we became aware that the government was rolling out fever clinics. We were fairly keen to see one in our area as well, for a number of reasons. We recognised that we needed somewhere safe for patients with respiratory illnesses to be clinically assessed and screened for COVID-19. These are people who would normally present in primary care, or those that were triage 4 and 5 and, in ED, and we recognised that this should ideally occur away from these facilities. Secondly, we are aware that COVID-19 would eventually become a primary care issue, given that most illness is mild and that only a minority will require high-level intervention. In addition, we had a fear that there would be community spread occurring in the form of milder illness prior to a significant impact on the vulnerable and the hospital system. Thirdly, I'd have to be honest and say we found it difficult to find a way to assess and screen for COVID in our practice because of various limitations, such as a shared waiting room, finding the right space, cleaning, etc. There's also the fear of an unwell patient bringing COVID-19 into our practice, putting our staff at risk, forcing closure of the practice with the ensuing clinical and economic ramifications. This has already occurred in the region with clinicians who have tested positive in our regional hospitals. So we were quite cognizant of that issue and we're very concerned. Fourthly, as a general practice, we have a high number of chronic care patients and elderly who attend our practice. And we know these people would be vulnerable to COVID-19 if they were cross-infected. And fifthly, the fifth issue was the hospital was providing excellent swabbing of contacts and suspect COVID cases, but there was really no mechanism in place to safely assess triage 4s and 5s by a clinician and screen patients with respiratory illnesses. We had a common waiting area, and the concern was pretty much the same as the practice, that someone would come in and infect the waiting area with other patients here that have come for various other ailments. And so the other issue was that we recognise is that there's been a significant reduction of presentations to the hospital and general practice. And look, that may be explained by a number of factors, such as, the reduction in infectious illnesses due to the lockdown measures, social distancing, absence of sport, reduced gatherings, such as schools, childcare, pubs. Maybe it's just coincidence, it's a quieter year, but maybe it's also fear that people are scared to come to facilities like general practices and the hospital, fearing that they may actually catch something. So that's something we were certainly conscious of. So we wanted to send a strong message to the public that it was safe to attend the general practice or the ED with illnesses, because people with respiratory illnesses and fevers would be seen safely elsewhere in a respiratory fever clinic. And 7, we also recognise the need for a regional approach, and we could see the importance of this fever clinic being part of a region, and that we were, working as part of an Australian response to managing COVID or certainly recognising COVID in the community. So the next slide, please. Look, we recognised very early, I suspect, like a lot of general practices, that we had to try and minimise contact with certain patients with the practice. What comes to mind very early is watching a video of an Italian ED in Lombardia several weeks into their crisis. The intensivist made a comment that the EDs unknowingly had become vectors for infection, with patients congregating in the ED and probably infecting each other. We recognised that COVID-19 would spread when unwell or symptomatic or minimally symptomatic patients congregate, not only in ED but our practices. So we formulated strategies fairly early. We embraced telehealth like a lot of practices have. Our practices in Mudgee have collaborated in our approach, updating each other of what strategies we were taking. We've provided signage asking people to call reception before they come in. The staff screen appointments before they turn up, and then doctors may choose to call some of these patients with respiratory illnesses, deciding on whether they come into the practice or go straight to swabbing after discussing this with the hospital. The other thing we did is we contacted our 3 large mines and asked them to change their policy on fitness to work certificates, so that we weren't having people that were well hanging around in the practice waiting for certificates that said that you were well, for fear of cross-contamination. We now conduct our flu clinics outside. We no longer have them in the practice. The fear is that, when we have them in the practice, people congregate at the front desk, and so we now have them outside. And we also approached the media and had a radio interview a few weeks ago, just reminding the public of what COVID-19 symptoms were, reinforcing messages of social distancing, asking people to stay at home with respiratory illness, and to contact GP surgeries if they are unwell, and discouraging people from presenting to ED with minor illnesses. So next slide, please. So in terms of the respiratory team and partnerships, let me start with the partnership. My colleague Gary Moore has worked very hard with council, who have been incredibly supportive locally, because really this is a community approach. It's a not-for-profit venture by the practice. It's really trying to keep our communities safe. And there's great benefit in keeping these patients with low-risk respiratory illnesses away from the hospital and general practice. Council has kindly helped with providing a location in Mudgee. We're working out of the showground and organising some demountables to be located in the showground. So that's been terrific. They've also provided us with administrative assistance with signage and some technical support. So a very big thank you to the council. We've also collaborated with our colleagues in the other general practice, some of whom will be working in the clinic. The hospital, we've been in close contact with the hospital, discussions with the HSM, and they certainly have our support. I've also had discussions with the ED nursing unit managers, the hospital in the home nursing staff, and they're certainly very keen for a clinical clinic to be up and running. We've had discussions, I've had discussions with our ambulance service. They, from time to time, they'll be called to people with respiratory illnesses who don't need to be in hospital, but certainly having a clinic like this in the community that is running 7 days a week would be very helpful. Furthermore, my colleague Gary Moore has been liaising with GP Synergy, the training body for our registrars. So he's had discussions with the state director to ensure a smooth transition for our registrars working in these clinic. In addition, we've had to liaise with our local emergency response team, and we've been lucky that we've been approached by two mines regarding our local mines regarding providing some PPE. So we're very fortunate to have such great collaboration. In terms of a team, we've got a practice clinic manager that with great thanks to the council who provided. We're delighted to have Marilyn working with us. She's had an induction already in our practice. We didn't bother waiting for the grant. We basically got cracking in Mudgee. So she's had her induction into the appointment system in the practice. And there's another administrator coming on board to assist with the roster for making appointments. We've appointed 3 casual nursing staff that'll work basically 7 days a week. We're looking at 4-hour shifts depending on the demands at this stage. They've already had their induction. We've just got on and paid for it and done it ourselves. And we've got a number of medical staff that'll be working in the clinic, a combination of doctors from both practices, and I've already had other doctors within town approach me saying they'd be willing to assist if needed. And we also include the cleaners as part of our team. They need to be on board in terms of what needs to happen with regards to cleaning and PPE. So we'll be involving them in certainly providing them with some training as well. So next slide, thank you. As you can see, the current guidelines as of the 24th of the 4th, 2020 are really fairly broad for swabbing for COVID-19. It basically includes anyone with respiratory symptoms or unexplained fevers. And really, we could all see this coming in the last few weeks. It was just a matter of just stepping it up, and we're now here. We're at that point where anyone with these symptoms, and as Dan Stewart said to me earlier, if they've got a nostril, then they can be swabbed, and I think that's a really excellent summary. And of course, there's those high risk settings, which I won't necessarily bore you with, but they're all listed on the computer there and on the slide. And of course, we'll swab anyone that turns up that's either been referred by their GP, if their GP is concerned and they've been sent to our clinic or the public health unit. We see ourselves as a government arm, and we'll be just swabbing and meeting the requirements. So just off to the next page, the next slide, thank you. So just quickly, we'll be entering notes in the clinic. We'll be using iPads. I've already created a shortcut for notes for the COVID consultation. I've already prepared a discharge letter for GPs. We'll either send that manually or through Argus. We're working on that at the moment. We'll be aiming to swab for not only COVID and do the NAT test, which is a nucleic acid detection test, but also we'll plan to probably do respiratory viruses as well, in line with what Dubbo are doing. We'll send copies to the usual GP, but we will follow up the results and also in conjunction with public health. In terms of management, look, we expect to see really probably anyone, kids with croup, kids with tonsillitis, adults with exacerbations of COPD, influenza, and my view is that we will just sort them out in the clinic and do what needs to be done. If they need prednisone, they'll get it. If they need antibiotics, it'll be done. My view is it's a one-stop shop, and it will just get sorted. And certainly if there's any need to transfer to hospital, we will be in touch with the hospital. So the view is it will be just a one-stop shop. And if people need to come back to the clinic, so be it at this stage. Next slide, please. Just a quick note on clinic operations. Appointments will be made by phone. We'll be using the software system in South Mudgee Surgery to make appointments, and they'll either be made through the phone number that we'll give to the community in the various practices, etc., or through our staff at the practice. We see ourselves booking 3 patients an hour, operating the clinic between 9 to 1, 7 days a week, and having the admin staff start at about 8 o'clock just to take phone calls. They'll be off-site. We've got a clinic protocol in mind. At this stage, the plan is that people will turn up by car. There is no waiting room. We will call people from their vehicle. We'll ask them to put a mask on. They'll be triaged by a nurse, and they'll likely go into what we call a dirty room with an expectation that any people with a respiratory illness will be swabbed. My colleague Gary Moore is working with the local hospital pathology regarding collection of swabs and what time that'll occur. And finally, last slide, really the big question is where to next? How long will this clinic go for? We know at least 3 months with an option by the Commonwealth to be extended. Will we eradicate COVID-19 in Australia? I don't expect an answer in this webinar. Will there be a vaccine in the near future? And really the big question for us is, how will we manage our general practices in the future if COVID-19 is not eradicated and respiratory clinics are no longer funded? And this is probably a question that's at the back of our minds here in Mudgee. What will happen down the track? And I know there's a lot of wait and see. Thank you for your time.
Thanks so much, Alex, for your time and joining us this evening. Now we'll hear from the Director of Emergency Medicine at the Dubbo Health Service, Dr. Dan Stewart.
Okay, I hope that's working there. Good evening, everybody. I know a lot of people probably online, but some people I don't, or for those who don't know me, my name is Dan Stewart. I'm a specialist emergency physician and I work at Dubbo Health Service, where I'm the Director of Emergency Medicine. And just recently I've been the clinical lead for our fever clinic, which we call the SAFE Clinic, which, in case you're wondering, stands for what is it? Standalone Fever and Flu Evaluation Clinic, because you can't do anything these days without a catchy acronym. I was probably like most of the people online prior to February 2020, where my understanding of pandemics and how we would respond to them would be purely theoretical. And in short order since then, people like me and all over Australia have had to become experts in the various stages and aspects of a pandemic emergency response plan, talking about how to respond with your given systems and facilities, how they can be adapted, modified and changed, all in a matter of weeks. The truth is that it's unrealistic to expect mere otherwise interested amateurs to become experts in the subject matter, it's been a major challenge for all of us, which hasn't been made much easier because of the constantly changing pandemic landscape either. But I think I'm incredibly impressed by the work that everybody involved with this project overall has been doing, especially with the PHN, who I've been working with from early March, as well as providing support and assistance, but also getting advice from the PHN itself. So just an early thank you to the group here for that. Tabitha has given me a list of sort of topics that she wanted me to cover that might be interesting to you, either from where do we go to from here, what the experience has been like, and some various other bits and pieces that, if not informative, may hopefully at least be entertaining, which I'll talk to now. Our SAFE clinic, or our fever clinic, we were asked to establish this on the 11th of March. On the 11th of March, we got the go-ahead, and they wanted us to start it at 8 o'clock in the morning on the 12th of March, which we did so. It was one of the first actions of the Phase 2 Pandemic Emergency Response Plan that was set up at a time when we were still expecting a major surge in patient numbers in mid-April, which of course hasn't come, but at the time we didn't know what was coming. Since the 12th of March, the SAFE clinic's been operating 7 days a week, 12 hours a day. On average, we're seeing between 20 and 30 patients in the clinic a day. Our biggest day, we saw 61. In the initial week or so, I was working in the clinic myself to bed down the systems and the procedures, and it was actually a lot of fun, I must say, at the time. Well, it still is fun. I still go into the clinic and help out periodically because it's different. It's good fun being on the front lines in a pandemic response, probably a once-in-a-lifetime opportunity for a clinician. Now, where are we going to in terms of our clinic in the future? That's particularly in the context of the community clinic starting up. We're going to continue operating 7 days a week, 12 hours a day for the time being, and potentially keep the clinic operating over winter as we start seeing seasonal fluctuations in respiratory presentations emerge. We may adjust the hours and we may adjust the coverage, but it's become a third part of our emergency department, and it carries a significant patient load through the day. 20 to 30 patients is nothing to sneeze at. So it's going to be flexible, and we'll be responding as the need emerges, particularly as the community fever clinic starts standing up and we start seeing more patients through winter. I was asked to comment on why the increased rate of testing is important across New South Wales and what's emerged to that. I don't by any means profess to expertise on the topic. I do have opinions about it, though. What I can understand about it, I think the analogy is like an Australian bushfire. And what we're debating at the moment, which Alex alluded to before, about whether we can exterminate coronavirus in Australia or not, is this idea of whether we can put this fire out completely, or whether we go down a process of having a controlled burn through the community. The fear initially was that this would be a catastrophic fire that blazed through our community that was intensely hot and wiped not just a significant proportion of the population out, but overwhelmed our community, our resources to deal with the sheer patient numbers as well as severity of illness. I think what a more realistic and probably preferable option rather than complete extermination of the virus is that we have a controlled grumbling burn through the community. The problem with exterminating it is that we can't keep our borders closed forever, hoping for a vaccine that might never emerge. At the moment, the fire appears to have subsided so much that it's hard to see where it is. Our testing numbers are significant, but the capture rate has fallen very low. Data I saw today for our region, we have a positive rate of 1.3% or thereabouts for the number of tests that we're doing, despite expanding our testing criteria at almost every iteration of the guidelines. So no longer can we see the smoke on the horizon. We're looking for grumbling embers burning in the bush, in tree stumps, in gullies. And that's why the testing criteria has been loosened so much. The aim of testing has always been to locate where the pandemic front is, where the collections of patients are, where it's moving and what it's doing. That is still the aim now, locating the pockets of spread. And once the aim of that is to know, hopefully establish exactly where it is and to set a baseline for where the pandemic front is as we start, and to measure the effects of the social isolation as we relax the social isolation restrictions in a stage-wide response to allow a very slow controlled burn through the community that doesn't overwhelm our resources. And that's why the testing is so broad, to make sure that we monitor the front and keep it under control as it moves through the community. What else was I asked to talk? So I've got notes here, but I can't read my own notes. Tabitha just asked me to mention the kind of work that we've been doing between the local health district and locally as well. So pretty early on in, I think, late February, Dubbo Health Service at least, and I presume the other facilities, established a COVID clinical leadership group, which still meets every day at 10 o'clock. From fairly early on, I've been our local Dubbo Health Service liaison with our primary health network here in Dubbo, where I live, and this is my home. But also I've been liaising just with the local GPs, who I know many GPs in town, and if I haven't met them personally, then I've certainly read letters from them and they've received letters from me. This has been really important for our local community here, not just to establish relationships, which is always important, but because here, just as in all the locations in the region, there are unique conditions locally with unique resource allocations and availability. And that means that the response needs to be tailored to what we have locally, as well as what the local community needs are at the time. I think it's been a fantastic example of standalone command and control models where local communities have got together and have worked out how best to respond to a crisis together. And I've been really happy to be a part of it. Why is it a good idea to set up a community fever clinic? Having standalone fever clinics, whether it's in the community or as part of the health service, is important for three main reasons. One, of course, is to cope with your anticipated increased patient load that comes with the pandemic. Another extremely important, valuable reason is it concentrates your necessary experience, equipment, and resources. And we very much saw that need early in the piece when we had multiple clinicians who were all very bright and talented, trying to grapple with the various guidelines and updates that we had available. And it was very helpful to have a single port of reference locally to provide the necessary guidance and expertise. And it's quite humbling listening to Alex talk because quite clearly Alex has taken that role in Mudgee, and to see people who I don't know what Alex's background is, of course, but I'm not sure he would have been 6 months ago anticipating he'd be an expert in this content 6 months ago, but now he certainly is. It's very impressive. And that just provides such a fantastic resource for your local community clinicians. Another very important reason why these fever clinics are so important is that it separates the patients who are at risk of COVID-19 or other respiratory illnesses from your business as usual patients. The latter group during a pandemic doesn't really get much attention, but they can be at significant risk of harm, morbidity and mortality during a pandemic response, because they get caught up in the hype about COVID-19 in particular. And there's plenty of examples and there's plenty of evidence to show that during a pandemic response, patients who wouldn't be considered at risk of influenza or COVID do still suffer harm, and they can suffer significant harm. And a lot of our processes that are designed to keep staff and patients safe do come at the risk of increased harm on the patients who may not otherwise be suffering from COVID-19, for example. And so a capacity to separate the patients out who are at high risk from the patients who are low risk enables some degree of business as usual optimal care for the non-suspect case cohort, and therefore a reduction in the risk for those groups. Tabitha asked me to comment on who should attend a fever clinic. The ultimate clinical governance for the community fever clinics will of course rest with the clinical leads there, so I wouldn't dare to suggest to make any determination there. But what I can say for our fever clinic is that we stream all Australian Triage Scale Category 4s and 5s patients with cough, cold, coryzal symptoms, rhinorrhea and flu-like illness to our fever clinic. Generally speaking, this cohort of patients would be considered to be safe for an assessment in a community-based general practice setting. We probably have a rate of 1 in 100 or 1 in 50 of these patients who are streamed to our fever clinic, who get snagged and then get referred back to the emergency department. And I think I wouldn't be surprised if we're getting if we've seen between 750 and 1,000 patients now. I'm aware of only probably 2 patients who've ended up being admitted from the SAFE clinic with a genuine illness. So the rates of serious illness in this cohort are extremely low. And the emergency department will always be there as a backup if a patient is identified who needs increased level of care or assessment. Now, Alex touched on the guidelines and what guidelines for testing can or should be used. Since the beginning of the pandemic response nationally, the primary set of guidelines for use is what we call the CDNA National Guidelines. They're put up by the Communicable Diseases Network Australia. The current version was released on the 24th of April, it's version 2.7. And these guidelines, until relatively recently, or until a few months ago now, but it seems recently, were informing the state response as well. The national guidelines have gone through 26 new iterations since their initial inception, and since we established the fever clinic, they've had 9 new iterations. On top of that, of course, you have the New South Wales health-specific testing recommendations, which make specific recommendations for testing in New South Wales over and above what is recommended by the CDNA. One of the biggest challenges has been staying up to date with the guidelines as they change and become updated. It's reasonably straightforward to check that the guidelines remain current. I do it every morning when I wake up in bed, and just check to see whether or not they've been updated. It's pretty straightforward to see if they've been updated, but it's a major challenge implementing particular changes to testing recommendations, working out how they affect your existing systems, and you need to take into account what your local resource constraints and availability are. And then on top of that, it doesn't help that the national guidelines, the New South Wales health guidelines, haven't always said the same thing, and in some instances have contradicted each other. And along with that, you get the occasional update from the chief medical officer, which doesn't, or an example is the Easter long weekend set of guidelines, which were released for 3 days only, and set a particular set of guidelines to be used for 3 days in order to increase testing, and then it reverted back to the old set afterwards. So I think this will be one of your biggest challenges for your clinical leads, keeping a set of guidelines that remain current, remain safe, and is also able to be practically applied within your clinical settings in the community. Fortunately, mercifully, the last iteration of guidelines are quite easy to implement, and they actually complement each other, and so there's no longer any sort of tension between the two recommendations. Our default within the community in the hospital, and I presume it would be within the PHN as well, was to keep the testing expansive as much as possible, adopt the recommendations that are for more expansive testing, and for at least the last 4 weeks or more, our testing criteria has been more expansive than either New South Wales Health or the CDNA guidelines. Hence the comment to Alex earlier that if you come in with at least one nostril, we'll screen you. I think I might stop there because I think that covers everything Tabitha wanted me to talk about. Yeah, thank you.
Dan, thanks so much for your time and joining us this evening. Now, I know that there's a number of other webinars happening this evening. The one with RACGP has just commenced a minute ago. We are about our hour up, but we might just rip through a couple of questions that have come our way for the presenters during the course of the presentation this evening. And Tab, if you're still online, I might throw this first one to you from Shirlene. Will the respiratory clinics only be treating the respiratory symptoms, and how will you manage the expectations of the patient if they want more service aside from respiratory symptom management?
Hi, and thank you for that question. And I guess that's where we have some amazing trained clinicians working in these services. And I think that we will really rely on our GPs and nurses to be assessing our patients and working out what their needs are. The respiratory clinics are established to deal with respiratory symptoms, but in saying that, if a patient has needs, and I think, these are patient, focused services, then they'll be attended to at that attendance, I guess, and maybe Alex could expand on that better, but the primary idea is to have them assessed quickly and swabbed where required, and then safely given information about what would be the best course of action following this. So they're going to get information about how long they need to be isolated, they're going to get information about when their results are going to come to them and how that will be delivered, and then information about how they need to get back into their usual mode of care. So that would be probably my answer, if that answers your question.
Thanks, Tab. Might stick with you for this one as well. Could you clarify whether the existing GP will be responsible to check up on patients, their progress, and indicating when they are deemed no longer infective? Thanks, Mary.
Yeah, so that will be, I guess, again, a decision for the clinic, and it's about good communication and understanding that the clinics are going to be looking at patients' respiratory pathology, including whether they have a diagnosis of COVID or influenza or what might be wrong with them, to be able to give good and accurate advice around how long patients actually need to be isolated or quarantined, and feed that information back to their regular general practitioner. And just keep in mind that our public health units are also set up to be following up with patients who have a diagnosis of COVID-19. They contact them every single day for the 14 days that they're in isolation, and they do contact tracing. So I think that there's a few ways that patients will be supported depending on their diagnosis, of course. But we're really keen to get good information back to the regular GP and then have the patient managed in their usual method of care.
One more for you, Tab. Another one from Mary. How is IRAD different to e-health records?
Yeah, that's a really good question. And we don't have Claire here tonight who's doing the IRAD implementation, but I did have a meeting with Southwest Sydney today. And to give you a bit of an idea of the concept, IRAD will give you just a view only, so you can't add to IRAD, but it will give you a view of a patient's hospital information, their general practice record, and you probably need Claire to expand on this, exactly how it works. But it's just a snapshot of that information on a different portal, on a screen, that's available for patients who are seeking services. I know that's not probably a great explanation, but with your e-health record, you need to go in through your software and go in and actually look at the interactions or the occasions of service or the summaries that are there. So I guess in theory, they've got a similar purpose, and that's why we want to pilot IRAD, do a pilot and see whether it's a useful technology. But it's to bring all that information together in one screen to be able to visualise it.
Alex and Dan, I might bring you in on this one from David. Alex, to you first. Are there many people with COVID-19 who do not present with respiratory symptoms?
My understanding is that there is a small percentage. I looked at paediatric presentations this morning, and there was an article in the New England Journal of Medicine that spoke about children also presenting with diarrhea and gastro-like illnesses. Initially, adults can be minimally symptomatic or asymptomatic for that matter. I'd probably defer to Dan. He's probably seen more COVID than I have, a handful more than me, but that's my understanding at this stage.
Yeah, that's right. I'm certainly not an expert on this either, but gastrointestinal symptoms are probably the most common, well-known non-respiratory presentation, and certainly the first case that we had in Dubbo presented with initially gastrointestinal symptoms and sat in the emergency department for 18 hours bed blocked until they left, and then were eventually swabbed on the ward. So the question has often been posed, if we know that some patients present with non-respiratory symptoms, should we not be screening these patients as well? The answer to that question is probably yes, reflected in most of the guidelines at the moment, where if you present if you have a fever or history of fever, you then trigger a set of drop-down epidemiological criteria that will then get you a swab as well, or you become a suspect case. And then also there's the category of patients who have fever of unknown origin. We know that there's a significant rate of patients who have coronavirus who have no symptoms. The percentage of that seems to depend upon the study and the methods of the study, but they do exist, asymptomatic carriage. Again, it's been put many times, and I'm sure it's being done in lots of other places where they're doing asymptomatic screening. But for places like ourselves, where there's limited resources, not just in swab kits, but in PPE, bed space, some kind of determination on risk profile, the patient population needs to apply. And at the moment, the rates of positive test results in patients who would be considered at high risk are so low at 1.3%. At the moment, there is still, at least within the emergency department proper within the hospital, still some effort to keep screening to people who meet existing guidelines and people who have symptoms of some description, which is reflected in, I think, both the CDNA and the New South Wales Health Guidelines. I hope that answers the question.
Thanks, Alex and Dan. Dan, I might hit you with another one from Mary. Can you be any more specific about swabbing criteria in regards to cough, and how would you guide if patient has chronic disease like asthma?
Yeah, no problem. So, the current, so we've just to give you a flavour, our current testing criteria or suspect case criteria for our fever clinic, which is very, very loose. There's two questions that the triage nurse asks. One is, has the patient been referred by a GP or a public health unit for testing? If the answer is yes, they will be screened. And then the second question is, does the patient have signs of an acute respiratory infection, cough, shortness of breath or sore throat, or fever, 38 degrees or above, or history of fever, chills and rigors? If they meet any of those clinical criteria, they'll be screened in our fever clinic. And that's about as loose as you can get. It pretty much just means that the asymptomatic person who shows up for funsies on the weekend won't be screened. Now, within the acute hall of our emergency department, operationally, we need to be able to establish who's at risk and who's not, a hot zone and a cold zone, in order to conduct our operations. It gets a little bit tighter, and this might answer Mary's question. So the first question is, again, does the patient have symptoms of an acute respiratory infection, cough, shortness of breath or sore throat? Now, there is scope within that definition that if you don't think the cough, for instance, is an acute respiratory infection, then they wouldn't trigger that, but they wouldn't snag that point if you're giving out points. And a good example recently was a person who had had a dry cough for 4 weeks and a background of ACE inhibitor use or something like that, and there were no other infectious symptoms, for instance. Or a patient who has regular hay fever symptoms under a certain circumstance, and they developed a runny nose and a slight sore throat. There is some scope within that to apply clinical judgment as to whether or not you think the symptoms are due to an acute respiratory infection. And clinical judgment is also, it's within the guidelines as well, both in terms of applying it to see if a patient realistically does meet some kind of risk for coronavirus, but also patients who otherwise may not meet any of the criteria, but in the clinician's judgment, they think that it is potentially high risk. You are allowed to make that judgment as a clinician as well. So I probably answered that question in many words when 2 would have done, but I think that to answer Mary, your question, that there is some, you need to be satisfied that the symptoms are an acute respiratory infection. And also, if you have a fever and you're not within the epidemiological criteria, if there's an additional source, it doesn't make sense to swab some of these patients. For instance, if you had toe cellulitis and a fever and didn't meet epidemiological criteria, that would not be a suspect case either. I'll stop there.
Thanks so much, Dan. Just while we're talking about testing, Dan, self-swabbing. New South Wales Health has said that the self-swabbing is probably not advised at this time.
Yeah, so speaking, I used to be a pathology specimen collector back when I was a medical student, and I was taught how to do nasopharyngeal aspirates, and I had them done on me as well. Self-swabbing is a silly idea and is completely unrealistic and will result in devastating sampling error rates. There is a technical skill to it. The CDNA guidelines has a specific section on how to perform adequate they call it a combined oro-nasopharyngeal swab, where you'll first swab the tonsillar pillars, and then using the same swab device, insert it into the back of the nasopharynx, which on average is about 10 centimetres from the anterior nares, and keep it there for 10 to 15 seconds, rotating it gently, then withdrawing, and then before the patient's had time to think about how nasty that was, do the other nostril. Now, there isn't a human alive who has the necessary technical expertise and who can tolerate doing that to themselves. And so I think it's a silly idea to think that people can self-swab themselves. In the beginning, we thought that the NAT coronavirus test suffered from a 20 to 15% false negative rate. And now that false negative rate is less than 1%. We think it has a lot to do with sampling error in the beginning. And if you get a good sample, if you've got coronavirus, the test should pick it up. And as I always say, a bad test with a bad false negative rate is worse than no test at all.
We've also received a thank you from Mary for your previous answer to that there, Dan, as well. Dr. Dan, Dr. Alex, Tabitha, and to all of our attendees, thank you so much for your attendance for this evening's web presentation from Western New South Wales Primary Health Network. We will have the associated information as well as this webinar being made available to you via our website within the next 24 hours. Thanks so much for your time and enjoy the rest of your evening.